This is the highlight of our day. Gives me a great deal of honor and pleasure to introduce to you my good friend, Professor Arun Singh, who is the Professor of Ophthalmology and Director of Ophthalmic Oncology in Cleveland Clinic, the COA Institute in Cleveland, Ohio. I could stay here for 15 minutes talking about Arun. I won't do that. I'm going to tell you certain things that are fantastic. Number one, Professor Singh is a wonderful man, as I was saying, and one thing calls my attention is, number one, the number of fellows that have left after training with him and adore him and talk about him all the time. Second, all the time he's invited to something, including a biopsy party in Denver during ARVO, he brings his fellows. The education aspect of Arun is phenomenal. The generosity of Arun is phenomenal. Of course, the competence and the knowledge are almost unparalleled. He is well recognized internationally. He was recognized nationally. And I don't believe we could have a better individual to give the 12th Vivian Sakely Lecture. Sakely Lecture was established by the Sakely family. It's a McGill University MUHC official lecture in oncology. And it's the very, very first time that the Sakely Lecture in oncology is given to ocular oncology. And the more, in my opinion, ophthalmology and ocular oncology, ocular pathology, and ocular activities are closer to other aspects in medicine, particularly immunology, radiology, dermatology, oncology, internal medicine, surgery, the better for us. It's wonderful to have eye institutes. It's not wonderful to be isolated. And Arun Singh represents the association of competence, dignity, and training, and I'm very proud that you are here. Arun.
All I have to wish for that 50% of it is true. Then I'll be very satisfied. It's a distinct honor and high privilege to deliver the first Vivian Sakely Lecture in ocular oncology. Wonderful to be part of this new group of people that I've met. I know some from before, but certainly it's wonderful to be here. I'm from Cleveland Clinic, been practicing there for almost 15 years, limiting myself to ocular oncology. But why mortality? So you heard about the diagnosis, the descriptions, and you hear about many, many papers on treatments and outcomes and whatnot. But really what matters to the patient is the mortality. And in all cancers, and particularly uveal melanoma is no different, that the primary aim of treatment is to eliminate or reduce a tumor-specific mortality. And that is the key, and we must talk about it. Incidence, it's approximately 4.3 per million. This is based on the SEER database, which represents about 26% of US population. It's the highest quality data that's out there as far as the population registries goes. And earlier today, we talked about uveal melanoma in blacks or African Americans or Africans. The best ratio is about 150:1. So it's predominantly a white person's disease, and age, as was also mentioned, is approximately 60 on average. Incidence globally varies, of course, depends upon the location. This is the US, this is talking about Scandinavian countries, even higher than US, for example. And if you look at Australia, it's about the same. And one knows very well that in Australia, there's a lot of sunlight, for example, and not so much up here. But the incidence is about the same. And this is Japan, of course, is a different race. So obviously, it is racial dependent. But among the white populations, it's approximately the same all across. This is the white population in Israel. And if you look at the incidence over time, this is over 25 years based upon the SEER data. If you go back even 25 years before that, the incidence of uveal melanoma has not increased. It's quite unlike skin melanoma, as you heard from Dr. Bang, and we know otherwise. So for uveal melanoma, the incidence is not rising at all. And Until 1980s, we had all kinds of treatments, and that's when the COMS came along in 1985, and Dr. Randy Simpson alluded to some of the key findings of COMS. So I think COMS really put the foundation of management of uveal melanoma on a scientific basis. Till that time, there were only non-randomized small studies, and there was a lot of controversy. So this is kind of the overall layout of the COMS. I do want to point out that COMS was limited itself to choroidal melanoma, but many of these things apply to uveal melanoma in general, excluding iris melanoma that may be slightly different. So for choroidal melanoma, we really want to classify them into small, medium, and size and offer them treatment. This was the key, I think, landmark component of COMS, which showed equivalence between the two treatments. This also did not really have any benefit of giving radiation prior to enucleation in large melanoma group. And this is the structure of the COMS. I'll come back to it again. Every time I diagnose a patient with choroidal melanoma, I tell them it's a small tumor or medium tumor or large tumor and try to guide them through the treatment options. So small melanomas, a lot of controversy about whether it's nevus or melanoma. We'll come back to that again. But remember, the base is 5 to 16 for medium and small tumors, and anything up to 3. Now, later on, they changed to 2.5. So 2.5 to 10 is a medium-sized tumor. So anything more than 10 in height, anything more than 16 in base is a large melanoma, because they could not be treated with the plaque, the largest plaque being 20 millimeter, according to COMS. So this is a criteria for enrollment. It's not necessarily a true classification, because that's not been validated. So how do you manage overall small tumors? You can observe them, because some of them, at least in COMS, 60% of them were true nevi. So majority of small, quote, small melanomas are actually nevi, so you can observe them, but if they have high risk factors, you might treat them with TTT or plaque. We know that if you follow small choroidal melanomas within the size group that I just indicated, only 30% will grow in 5 years. So that means 60% are actually nevi within this group, or even more than 60%. So this is key, I think, finding that doesn't seem to be highlighted out of COMS, that within small choroidal melanoma, 2/3 are actually nevi, based upon lack of growth in 5 years. So that tells you that when you diagnose somebody with small choroidal melanoma, based upon size only, then you have to start thinking, is it a nevus, is it a melanoma? But statistically, in that group, 2/3 are nevi. I will come back to it again. Some of them, people can treat them with TTT, and all I want to say, the TTT is very good for nevi. So if you think about a patient with nevus, you treat them with TTT, it will never recur, it will never metastasize, and you'll have excellent 100% control. But basically, you just treated wrong group of patients. So just remember that TTT overall is effective for nevi, maybe for some small melanomas, okay? If you look at the recurrence rate, it's approximately 20%. This is the published meta-analysis of about 660 cases that had been published by the time we did our survey. 20% at 2 years. Whereas plaque radiation, if you know, the recurrence rate is not more than 2% or 5%. So it's important to know local control is important, because local control also influences the risk of metastasis, the recurrence being a risk factor for metastasis. So if I have a tumor, say, let's say prostate tumor, and I go to an oncologist and he says, oh, I can give you a treatment that has 2% recurrence, and I can give you a treatment that has 20% recurrence. Well, it's important for me to have 2%. Because that gives me the best control. Best control also reduces the risk of metastasis. So this is important concept. We are not just treating a lesion with laser, we're talking about metastasis, and therefore think slightly differently. Not only you can have TTT, will give you local recurrence, but you can also tend to have extra skilled extensions, eventually requiring enucleations. How about medium? The standard of care, at least in the United States, is plaque radiation. 85% of medium-sized tumors in the United States undergo plaque radiation. Alternative, they can get proton radiation. Stereotactic is not widely used in the United States, again, because of risk of neovascular complications and popularization of plaque radiotherapy since COMS, and you can see the trends as we go. Of course, if there's no vision potential in that eye and patient wants, we offer enucleation. So what did the COMS show for medium? They randomized the cases, and we found equivalent results. Brachytherapy, typically in the United States, we use higher than 135. In Europe, they also use ruthenium. Ruthenium has some advantage for smaller tumors because it's more focused radiation, so the collateral damage is less, and you may have better outcome of visual acuity, particularly if the tumor is near the macular area. How about large tumors? So I just tell the patients based on size, if it's large tumor, I say the treatment of choice is enucleation. Now, if that's the only eye, for example, and the tumor is more peripheral, you may offer them, say, alternative therapies. But I start with enucleation and discuss something else. So for medium-sized tumors, I talk about plaque and put enucleation as an alternative. For large tumors, I offer enucleation first and then talk about alternative. So it's just the way how you frame your discussion that kind of makes it easy. So there's nothing wrong with enucleation. As you all know, you have beautiful outcomes here cosmetically. What about the mortality overall among the COMS for 5 years? And we talk about tumor-specific mortality. This is slightly different than overall mortality, because in this age group between 60 to 75, for example, patients can die of many things. So if you look at the literature, they talk about survival, mortality. I'm focusing on tumor-specific mortality. That may be 30% lower than overall mortality. Tumor-specific mortality is lesser than overall mortality. So for small tumors, it's only 1%. So if you have a 90-year-old patient, for example, who has had a triple bypass in the past, is on Coumadin, is confined to nursing home, is having dementia, and you diagnose small melanoma, you really can leave them alone or at least follow them closely, because the risk of dying from that small melanoma is only 1%. In fact, in such a group, the chance of dying from something else is much higher. So that is also important, how you counsel them. Talking about medium-sized tumor is approximately 10% in 5 years, and large tumors is about 25. So this is just a global number, so we'll kind of refine them as we go through our talk. What about temporal trend over mortality? What happens? You say, well, 5 years have gone by, am I cured? No, not really. Based on the best data that's based on enucleation over very long-term follow-up, we know that about 60% of the risk is manifest in 5 years, and approximately 90% in 15 years. So somebody who's 50 years old, had enucleation, and now is 65 years old. He still has approximately 10% of the risk of whatever the risk that was when he started with. So his risk was, say, medium-sized tumor was 10%. You can estimate that he still has about 1% risk left at that time. So that helps you in counseling the patient, certainly helps me, how I propose surveillance techniques for future management as to imaging, et cetera. We'll get into that some more. And how about the relationship between all-cause and tumor-specific mortality? When somebody is younger, say, then the risk of dying from metastasis is higher. And as the time goes on, they get older. So average age is 60, now they're 75. At 70, at 15 years after enucleation, equal chance of dying from melanoma or something else. And once they reach 20, 25-year follow-up, the risk of dying from something else increases, and the risk of dying from melanoma decreases. The longest interval we know from enucleation to metastasis is about 53 years or something like that. So these cells can stay, say, in the liver at least for that long, 50 years plus. So you never really get cured for melanoma. It's just the odds of getting metastasis, manifest metastasis, goes down. And we'll talk about that some more. And what about the trends over time? So not just my experience, your experience, but population-based studies out of SEER, a database. So enucleation and resections have gone down in the United States, the rates of radiotherapy have gone up. And that's, again, mostly from 1985, which is kind of here, where the COMS came along. And in the COMS, the only radiation was plaque radiotherapy. So it's not surprising. But what about the survival? What about the survival? Survival hasn't changed. So this is adjusting for the change in life expectancy. Okay, so life expectancy in 1973 versus 2008 in America has changed. So you're adjusting for that, and therefore there's relative survival. So it's a 5-year relative survival. If somebody was diagnosed with melanoma, uveal melanoma in 1973 versus somebody diagnosed with uveal melanoma in 2008, the risk of dying is the same. So we really haven't done a whole lot of, let's say, improvement in patient's outcome if our main outcome is survival. And we never really talk about it. You don't ever hear about this kind of stuff. The first time I wanted to publish this paper in ophthalmology, I had a hard time getting it through. Nobody wanted to publish this data because it was for the first time showing that the survival has not actually increased. And we have done One more paper after that, and I'm publishing every 5 years. So I'm waiting for 2014 data, which is coming out now, for a paper which we'll write next year. That will extend this. I'm hoping, I don't know which way it will go, but it will tell us the more recent data. So this is 2008. That means 5-year follow-up, 2013. So it's covering up to 2013 data. Okay. And so this is the one of the major landmark papers that Rand Simpson showed the data from. This is from 2006, also 10 years ago now. And I want to just very briefly look at it and say, well, the outcome at 12 years is almost about 19, 20% is the mortality. Let's say whatever number you want to put it, 18, 20, yeah? So that's 2006. And I want to take you back to an older paper that also comes up with a number. I can't understand the German here, but the number is very striking, about 18 and a half. Just to highlight a point, and this is Ernest Fuchs, and I think it's 1882. So you can go back as far as you want. The numbers are of the same. All I'm trying to say is that we haven't really made a difference, and the question is why. And I think if we try to answer the question why, maybe now we can do something else. So that comes down to the pathobiology of uveal melanoma, and some of it may be how the primary and the metastasis, how they grow, how they manifest, and when does the metastasis happen. And this is something I published several years ago, again after long struggle with the editors of Ophthalmology, essentially showing, if you were to look at the mathematical doubling times, etc., all it shows is that the metastasis happens when the tumor is very small. So this is the onset of metastasis. This is the so-called small melanoma that becomes detectable, and the metastasis catches up later. That's about 2.2 years later. This is the same difference from here to here is what Zimmerman showed in his paper, the highest mortality 2 years after enucleation. So it has nothing to do with enucleation. It's to do with the timing of when the metastasis happens, how fast it grows, and how the small melanoma becomes more detectable. This time maybe, this is approximately 5 to 6 millimeter in diameter at this time. So it's the timing. So basically, all you have to understand is that uveal melanoma is a systemic disease. And all you're doing to the eye is a palliative therapy. If you just get these two words in your head, you know how all this fits in. And that's because by the time metastasis happens, the tumor is actually small. The metastasis has already happened by the time the patient has come to you. So we think we are being curative, but that's our intent mentally. We think we are curing the patient, but all we're offering is the palliative therapy. And when you say immediately, you start to think palliative means palliative is only patchwork, okay? So why is that? Because metastasis is early, and there are many reasons to believe that. It's hepatic predominant, we know that, and it's rare at presentation. It's already there, it's just not detectable. So if you think about it, melanocyte gives rise to nevus, and nevus somewhere becomes a melanoma. Two kinds, metastatic melanoma and say non-metastatic melanoma. So this is low risk and high risk. When you say low risk and high risk, both of them have micrometastasis. In both of them, you can find circulating tumor cells. In some of these, in this group, this micrometastasis will become macrometastasis. And the other, micrometastasis, will not convert to macrometastasis. So the change is only here. And what drives it? Perhaps the genotype of the tumor itself and some immune surveillance mechanisms, and et cetera, that we don't know yet. But not everyone, we say, with class 2 tumor dies of metastasis. And we also know that some class 1 tumors also cause metastasis. So micrometastasis is universal. The difference is between micro to macrometastasis. Let's look at some other determinants of metastasis. We talked about the size, we talked about the location. Iris is better than, for example, a ciliary body. We also talked about epithelial cells, tumor-infiltrating lymphocytes, extraocular extension. These have been known for some time. And more recently, for approximately 20 years now, monosomy 3 came out in Lancet in 1996. That was the first paper that showed there was a correlation between the genotype and the risk of metastasis. And of course, this is an older paper of ours. You can see this is the old style fish. You can see staining the whole chromosomes. This is normal. And here you have, in the tumor sample that has risk of metastasis, you have only one chromosome 3 instead of 2. In normal, you have only one red. And this is the old karyotype. You see one of the chromosome 3 is missing, and the chromosome 8 is duplicated. This is the old style karyotype that's been now shifted to fish, which is kind of easy to see. So either monosomy 3 or duplication of 8q and combination being worse causes the risk of metastasis. Patients who have this kind of tumor have practically no risk of metastasis. And the difference is approximately half and half. Half the cases have this, and half the cases have that. So you basically have two kinds of, or maybe more, of uveal melanoma. So this is, you can do it also on a single cell, for example. This is after cell suspension. You can do this as a normal, two disomy, that's great, and this is only one dot, should have been 2 dots. So that's tell you this monosomy 3. That's the easiest and the earliest, some of the earliest work related to this. And let's talk about FNAB. FNAB is very safe. We talk about hemorrhage at the biopsy site. Visually significant hemorrhage requiring vitrectomy, 1%. Metastasis retinal detachment, 1%. So 99%, the risks are very, very low. Again, what happens is, at the biopsy site, the tumor acts like a buckle. The tumor itself is a buckle. So there's no retinal detachment or very little. And the point of entry seals maybe through the blood itself acting like a glue and just seals off. So it's very rare to see retinal detachment for the properly done FNAB. And we published our monograph, and so the credit is not ours how we get the sample. I think you really need a high-quality cytopathologist who are able to tell you reliable interpretations. So we know on FNAB that 95% plus, almost 98% of melanomas have spindle cells, and about 80% have pigmented cells, melanin inside them. So that's the diagnostic criteria. Again, overall low complications. But that's the FNAB for prognostication purposes. We also know that patients who have monosomy 3A2 duplication have bad prognosis, and that do not have it have excellent prognosis. This is from 2001. So there is nothing new. It's been known for 15 years that patients who have genetic imbalance, a bad prognosis, and those who do not have excellent survival. So we know there are at least 2 kinds of melanoma. So, and more recently, we talk about CMA and different techniques, SNP, MLPA with gene expression profiling. This is another way of showing the same thing. Here, there's only one chromosome 3, for example. And here is with SNP, which is a DNA-based technique. Again, you can do differences between disomy and monosomy. Based on MLPA, again, you have excellent survivals. So you're able to discriminate prognosis with high accuracy. That's what, no matter which technique you use. Look at gene expression profiling, also similar. So this straight line and this tells you that. So we have 2 commercially available tests now. One is the gene expression profiling, and the other one is MLPA. I don't know why A dropped off. Both are commercially available, and in my mind, you can use either one of 2. The advantage with MLPA is that it looks for GNAC and GNA11 mutation to confirm that you actually have a tumor sample in your biopsy. So it kind of gives you an indirect clue that you're analyzing the tumor sample, not something else. Whereas gene expression profiling, you do not have that kind of confirmation. So you do not have any diagnostic confirmation, you only have prognostic confirmation. So you cannot say, I have a class 2 tumor and therefore it's a melanoma. That's wrong. And you cannot say it's a class 1 tumor and therefore it's a nevus or it's not a melanoma. That's also not true. So class 1 and class 2 only reflect upon one aspect of the tumor. That's the risk of metastasis. Even class 2 tumors can grow, fill the eye, cause total detachment, cause neovascular glaucoma. Can have extraocular extensions. Everything can happen between class 1 and class 2. And there is nothing we know, at least on clinical exam or ultrasonographic features, that will differentiate one from the other. So coming back to this, so we know that GNAGQ11 are early mutations that give rise to nevus formation, and then there's certain mutations that drive non-metastatic melanoma, and the BAP1 mutation, which is here, that drives this pathway. So we are starting to learn the genetics of the different pathways, but we really don't understand we also understand, most of the data indicates that there's very little conversion from this kind of melanoma to this melanoma. So I know Dr. Banier showed a case that had like 2 areas. Maybe there are 2 melanomas starting there. There's no data to indicate, because we don't have sequential biopsy, to say low-grade melanoma converts to a different melanoma. So somewhere early on in the onset, they bifurcate. And they kind of, as far as we know so far, they kind of stay distinct. Okay? And so we're learning to learn the biology or the genetic changes. And of course, there is some immune mechanisms going on. There are microRNAs in the blood, for example, that correlate with that. There are other immunoglobulin proteins that we do. Basically, in presence of uveal melanoma, you have immunosuppression. So your immune system is suppressed. The melanoma suppresses immune system. That's how it can survive. And there are markers in the blood that you can pick up. And that takes you into the biomarkers, and you heard very nicely from Julia all about a liquid biopsy, and she was talking about this, circulating tumor cells, circulating tumor DNA. But you can also study circulating microRNA, which is a marker of kind of immune response and other responses happening to the tumor. Tumor is, after all, a foreign cell. So you can study those two. Okay, so biomarkers, and I think that's the future, because that's obviously not an invasive technique. For someone who has only one eye, excellent vision, and for sequential follow-up, you might be able to do that. So we have some interest in this, and we are working on it. So if you really want to then reduce the mortality, what are you going to do? Well, you have only two approaches. One is to do early diagnosis and treatment of the primary tumor, or you do early diagnosis and treatment of metastatic tumor. We know because metastasis happens early on. So you say, you know what, I'm going to catch the tumor before it metastasizes. So that's one approach. Or you're going to pick up the micrometastasis and try to treat that. So those are the two broad approaches for reducing mortality. A little bit about the small tumor we talked about. Again, the mortality related to size, so size is important. And then Dr. Simpson kind of came back to the same thing. So how do you tell, is it a small melanoma? If it's not a melanoma, we don't have any definitions. People have tried to use size, for example. People have tried to use cross-sectional area. People have tried to calculate volumes. Most of them rely on growth to say if there's a growth, it's melanoma. If there's no growth, then it's not a melanoma. So that's kind of is one way to differentiate many times for melanoma versus nevus. So you can see stable lesions like he showed, and you can have tumors that grow. And then typically, how do you know which one it is? And I think if you look at the published data, the growth rates can go from 0 to 31 to 41%, and inclusion criteria is all over the place. So it just depends. If you have nevi in your inclusion criteria, your growth rate is 0. If you have all kinds of tumors, then your growth rate is high. So all these numbers don't really mean anything, because everyone has different inclusion criteria to define what they call is a nevus. So we come back to the COMS again. According to COMS criteria, we know 60% are actually nevi. And so if you come back to the terminology, why should we call them small melanoma if 60% in this group are actually nevi? And then what is atypical nevus and what is large nevus? We really do not know, because we keep describing it. We really need to have a size-based thing. So I really think we should change all that to say call them the indeterminate lesions. So come back to the COMS and say, well, here is small melanoma, 5 to 16, 1 to 2.5 now, and these actually are indeterminate lesions. We don't know exactly what they are. Some of them are nevi, some of them are melanoma, 3 to 1, and there may be some, maybe that's in between, we don't know. So this is a mixed group. So how do you tell if a patient has nevus or melanoma within this group? And I think that's where you come down to a diameter, thickness, and the presence of orange pigmentation. So if you have orange pigmentation, and also some people will think subretinal fluid, you start to think that it's more like a melanoma. So we tell the patient you have indeterminate choroidal melanocytic lesion, based upon the fact that you do not have orange pigmentation, because it's less than 2 millimeters, because it's less than 11, less than 12, we think it's a nevus. And because it's more than this, we think it's melanoma. So you tell them that's what they have, and based on clinical criteria, we favor this, we favor that. And the moment you describe these things, those patients have a more than 50% risk of growth, not 100%. So this differentiation is a relative scale to say you're less likely to grow or more likely to grow. But growth can happen either way. So you'll say, I followed this patient and patient died from it. Of course it can happen. And you say you have melanoma and had everything and never grew. So that's all possible. So of course you have neuroimaging studies such as OCT, etc., to help you find lipofuscin, subretinal fluid, autofluorescence. All those things help you detect the features that define the risk of growth. So we're not going to go into that. But that you kind of get an idea as to where you place them, and then you advise them treatment based upon it. And how about the more important one, I think, early diagnosis and treatment of metastatic disease, which is micrometastasis. So let's come back to micrometastasis. It's an early event, it's in liver, and it's a rare presentation. So how can we detect? Well, we can detect circulating tumor cells, but it's not going to show up in the liver, so you need biomarkers. So you need something to tell in the blood about these circulating because you can't image them in the liver at present anyway. And can we predict who has this risk of micrometastasis to macrometastasis? Yes, we already have those two tests that are commercially available, validated, and that can be used for clinical application management. So we have that area. The biomarker is a very, very interesting area of research. And then treatment. Why don't we treat them when they have micrometastasis, particularly those high-risk patients? And that's the future, I think, of uveal melanoma. Let's talk about adjuvant therapy. Adjuvant therapy is therapy given in addition to the definitive therapy. So you treat the melanoma, enucleation, plaque resection, TTT, whatever you think. You have done that. And on top of it, what are you going to give? Keep in mind that these patients are totally asymptomatic. They have excellent quality of life. So you cannot give them drugs that will put them in ICU or will cause certain mortality or cause debilitating side effects. We have had patients with ipilimumab who developed iritis in the only eye that's left after enucleation, for example. So you can have those kind of complications. So you have to keep in mind these patients are fully functional, they are at high risk of metastasis, but they have no compromise to quality of life. So how do you detect micrometastasis? In clinical applications, LFTs are useless, chest X-ray is useless, hepatic imaging we do at a baseline, that's just to stage the disease, but really not to detect micrometastasis. So we are not doing anything clinically that helps us to find micrometastasis. We do staging. I think for every cancer you should do staging before you treat them, and we do ultrasound every 6 months for surveillance. And I want to talk a little bit about this ultrasonographic for surveillance. And we did that, we published it in JAMA, it just came out a few months ago. So if you look at the patients with ophthalmic diagnosis and metastasis diagnosis, and the red is where they die. These patients were imaged only when they became symptomatic. That means they had no surveillance. They die at a certain point. Patients that were imaged with liver function test, they died at this point. And then with ultrasound, so what's happening is with ultrasound, you're picking up the metastasis early, but they're dying at the same time. So there's a lead time bias. You're just catching it early, but you didn't make any difference once you found it. So if you're a health economist or a policymaker, you say, oh, this is useless, don't do it. Well, yes, I agree. It's not. So we published our own data to show that there is no real difference from this point to this point is fixed. All you're moving is the arrow here or there. So it's telling us that at least present status indicates that imaging, even if you find early metastasis, may be good for some patients, I have to say. A patient's mental satisfaction and are equally important. All that is good. But overall, did not make any difference in survival. So that's the present state, okay? So none of these are useful, so I think we need to think of biomarkers. And a lot of work has been done in Dr. Bonier's lab, and I do want to acknowledge that. And come back to adjuvant therapy. So what is adjuvant therapy? We mentioned that, and why must we do it? So here we have a patient that we can predict very well that you're going to get metastasis with high accuracy, 98% versus 2%, so that's very good. And once you get metastatic melanoma, you're going to die pretty soon after that because it's untreatable. So you're able to tell with high clarity, yes, you're going to get metastasis and you're going to die from it. But you're not able to offer them anything. But as a patient, do I want to know that I'm going to get metastasis 2 years from now? Or do I just want to continue and see what happens? Maybe I will not apply for my next job as a chairman and continue to work. What the hell, I'm going to die of meds anyway. What do I have to do? Or why just take a long vacation? Won't get married or who knows what. So it's very important when you offer this kind of testing. So we have a counselor who counsels them before we actually do the test. And we also published the depression, anxiety, and it's called decision regret. So patients will regret making a decision of wanting to know the results once they know the result. They said, I wish I never known that. You know, we regret shopping, dating, all kinds of stuff we regret sometimes, yeah? Same thing. They make a decision to know the results, and then 3 months later, they have a decision regret. So we did a formal longitudinal study where we captured that using a special questionnaire. And there is approximately 5-10% of patients who will have a regret. Even if the results are good, they didn't want to know. Sometimes. So this is very important. I really want to. And so the treatment that you maybe want to consider giving them could be targeted therapies. And Dr. Wong gave a very good overview about targeted therapies. That's because these patients are fully functional. And you can't give them highly toxic drugs like chemotherapy. And so you really have a role for targeted therapies. Let's talk a little bit about it. So the difference between chemotherapy and targeted therapy is that it is specific, but they're also cytostatic. That means they only work for a certain time, like she said. And after that, the tumor comes back with vengeance. So they're not curative, number one. Number two, they don't give you this. In chemotherapy, you study relapse rates. Here you talk about progression-free survival. You talk about time to progression. You don't talk about overall survival, because that's not going to change. You're only stopping them from reaching the end point. You're just delaying that. So that's how the targeted therapies work. And they're generally well tolerated. Immune therapy may change, that changes the overall survival, like ipilimumab, etc. Again, she mentioned, is she here still? She mentioned $100,000. It's actually in the US $400,000 for 4 months of survival. So ipilimumab costs $400,000 and gives you 4 months extra life. Out of that 4 months, I think 1 month is in the hospital, going back and forth. So you can judge for yourself how much cost-effective it is. I guess life is worth a lot, but in any case, think about that. So again, we talk about different pathways. We already have drugs that work in different things, and she mentioned some of that. So in uveal melanoma, I would say that we've published a recent survey. Please go back and look at it, but I want to highlight some of the key findings from our survey. So these are the older studies, where this goes back to 1990, so it's nothing new, but these were not risk stratified. So they just enucleated the patient and put them and gave them some treatment. So they could be low-risk patients, and those low-risk patients will never benefit from anything, and they really should not be included. So these are the older studies, so we really don't want to go there. And these are the current trials, and what are they talking about? Crizotinib, ipilimumab, which is a treatment for skin melanoma, is being tried as adjuvant therapy for uveal melanoma. And again, for high-risk cases. So these are the trials that are still available, and this list keeps changing. So if you want to check out, go to clinicaltrials.gov, and there you can get the latest status, and these are risk stratified. So there's also vaccines, there's ipilimumab. This is what we finished a few years ago, and waiting for a 5-year outcome on this. And I want to give you some more. What are these? These are, so this is what we did a few years ago. So we took 150 cases, and we prognosticated them all. We offered them, and most of them accepted. We also did psychometric analysis that's mentioned, decision regret. And we also did biomarker samples. Okay, some of it is published using microRNAs and things like that. And once they were in high risk, we gave them adjuvant therapy. That was an experimental protocol. And we had cytologists, pathologists, psychometric, proteomic, oncology, all of these people kind of working together. And that's what you need to do good work in uveal melanoma. And so we found out that approximately 43% had monosomy absent and 42% had present. That means half and half. Good prognosis versus bad prognosis, approximately half and half. Just easy to remember. And then if you look at, so these are eligible patients, only half of them enrolled. So we started with 150, we have only 33 in that trial. So think about how many patients do you need, because these patients are healthy. They don't think there's something wrong with them. And you start to say, oh, I'm going to give you this infusion, I'm going to give you this pill, you can get flu, you can get this illness, you can get bone suppression, different infections. So they may not necessarily be very keen to jump onto your trial. But think about all those barriers to enrollment. So we only ended up having, and this is not through me, of course, we have oncologists who are running this part of the trial. But anyway, so we are working on a 5-year follow-up. So unless we do adjuvant therapy, I don't think this curve is going to change. So we can keep treating TTT, or we can keep treating enucleations or plaques or proton or stereotactic or vitrectomy, silicone oil, whatever you want to do. And I have no objection to any of that. Okay? But we really have to start thinking in terms of adjuvant therapy. So there are drugs out there, and some are coming quickly in the market, and we'll have to start using them. Thank you very much. It's a distinct honor to share our experience.
Nicely put together, a lovely treatment. And you're right. This is actually one of the first slides I show in other lectures, that nothing's changed. And certainly, unless we get to a point where we can have some kind of a silver bullet, we're not going to make any difference. However, having said that, we have to somehow define a way to put people into different potential therapy categories. So I think maybe the cytogenetics is one avenue. In other words, you give the person the chance and the thought that they might go into a category, and this would be one way to define who they are. My concern has always been that that because we don't validate or haven't validated what we're doing now with biomarkers, I mean, we have a lot of information about it, but we really don't know for sure down the line whether we're going to be right or wrong. My concern has always been that we sometimes deliver false information to people and discouraging information to people. If we give them the answer that, for instance, they don't have a very good result coming up, that's not very helpful. So I think you've got to be cautious about the clinical approach to information, as you pointed out. But certainly, because there is no silver bullet, we have to keep working and trying to find the answer.
I want to make a comment in the sense that whatever we come up with probably has to be, number one, a drug off-label, already FDA approved. Number two, minimal, very minimal side effects, particularly because of that the patient doesn't see that he or she has something. Thirdly, it's going to be based much more in laboratory work and translational research than in clinical, because we're going to be waiting for 10, 15 years until we have groups of people to compare in terms of metastatic disease. Where I see we make a difference, perhaps, is studying, for example, NM23, proteins that can modify the levels of CMAT, anti-COX-2 medication, perhaps even Gleevec, medications that are already out there, where we can pinpoint for a number of years that we can perhaps arrest or make much slower the progression of the disease. I think we are far from the silver bullet. And I think the silver bullet is going to be a combination of do something to the cells that are circulating, plus certainly do something to the liver. Because we have one of the animal models we have, and Patrick Logan described it, it's in a nude mice where we put cells in the tail vein, and 14 days later, or 7 days later, all the cells are concentrated in the liver, nowhere else. And we do GFT, or green fluorescence protein, and we mark the cells. And then the liver has an attraction, or those cells are attracted by the liver. Then I think we have to combine something that stops what the liver does, plus stop or help the cells not to stop there. Killing the cells, circulating malignant cells, is much more difficult because you kill also good cells, and this gives to the patient a huge side effect. That's the way I see it. Silver bullet, I think we're going to wait a little bit more.
So there are certain drugs in pipeline, and we didn't get into the actual targetable targets. There are certain targets already known, and there are groups. Our group, we have certain drugs that we've identified, and we're putting a trial together. So all this is happening. I mean, the worry is that you may actually have more trials than the patients, because everyone wants to push their drug, and you'll never have hundreds of patients that you want, because you only see so many per year.
And I'd like to make one more plea for a registry style, a large database style of evidentiary results before we look at anecdotal improvements in novel therapy. The only way we'll ever know whether something works or not is to put a lot of cases together.
Oh, yeah.
And I think that the multi-center approach has to be accomplished in this global information world of ours, and I think it can be done. And so it also has to do with novel therapy. Certainly the pilots can be done, and if it looks reasonable, then go ahead and open it up, but we need numbers.
Right. I think there was a comment at the back, yeah.
That was totally brilliant. And the concept of micrometastasis raises the issue, how many patients in your practice present with the liver metastasis at the same time as they have an ocular melanoma?
1%, detectable.
And does that change the management then in that patient?
Okay.
They already have a liver metastasis.
Okay. So we always image our patients before enucleation, before plaque, because I like to know the disease. And if they come up with, say, liver lesion that's highly suspicious on CT scan for mets, then we will stop the eye therapy and we get an oncologist evaluation. And if the oncologist says, yeah, and patients are very keen to intervene at least up front, and they say, yes, we like to have laser ablation or want to have biopsy, whatever. And then the argument is, if you're going to treat the metastasis, then you have to treat the primary. You cannot not treat the primary and keep going after the metastasis. So you say, okay, we continue with the enucleation and you continue with the liver mets. So that's kind of where we are. Because I think there are very few patients who will then say, or I haven't come across any in my practice, who will say, I'm not going to have anything and I'm just going to walk out of the clinic and thank you very much. The family and all those things put the pressure to at least undergo the first-line therapy. And if they fail, then they may change their mind. Yes, sir.
Yeah, I just want to make a comment that for once I'm going to agree with Dr. Bernie here, in the sense that we have to focus a little bit more on what happens in the liver, because I think there's this huge knowledge gap between primary and metastasis. The prevailing assumption is that it's a linear process, and I'm completely unconvinced of that. We don't know if the cells in the liver that are there upon inception, the ones that are circulating, or the ones that are capable of metastasizing, whether they undergo further mutations in the liver that permits them become macro metastasis. I think there was one patient where he had enucleation, developed liver metastasis, had the liver removed, and then he still developed a subsequent metastasis after he got the donor liver. So there's this repository that exists somewhere, probably in the bone marrow.
Yeah.
Your opinion is whether you think that this is critically important.
Yeah, it is, because all we are characterizing is a primary tumor and the patients are dying of metastasis. So what's happening to the cells in the liver? So we did one study, and again, as ophthalmologists, we have limited access to liver biopsy samples. Many times they just do, say, a needle biopsy, and then they get, say, radiation sphere treatment, for example. You never have any more sample. But in 10 cases where we could find matched eye sample and the liver sample, we found that all of them had monosomy 3 8q duplication in the liver sample. So these changes persist in metastasis. Now, monosomy 3 is also detectable in circulating tumor cells. Now, do they get something else once they reach the liver? I do not know. But at least those common phenotypes are present in the metastasis. So that's there. And they probably we know as cancer advances, there's accumulation of mutational changes. So there are other mutational events that are happening. Yeah. So we have a liver surgeon on board as a trial. If they do liver ablation, we will take some sample from them and freeze it and those kind of things. But again, those are smaller numbers, and we haven't really done a whole lot of analysis on that. Before we finish, I want to say that TCGA, Tumor Cancer Genome Atlas, it was an NCI project where they did multi-platform analysis of genetics, RNA, et cetera, for breast cancer, lung cancer, prostate cancer. Just finished analysis of 80 cases of uveal melanoma. And that will be published, I think, in a week or two. We are part of that group, so I have access to the manuscript that will be published. So that has a most comprehensive analysis of all mutations, all RNA, all proteomics, everything that you want to know on 80 cases of uveal melanoma funded by the NCI. It's going to come out, I think, in next few weeks. So that will be a very landmark database to then start working from there, looking for targets and liver samples, et cetera, et cetera. Yeah.
I would like to thank Dr. Hussein for a wonderful
Thank you.
stately lecture. In the name of McGill University and MUHC, thank you very much for being with us. I'd like to thank all of you for being here. And I'll see many of you tonight. I'll see many of you tomorrow. And biopsy continues. We'll see you guys.